Welcome to this 14 Fish Facebook Live. So tonight we're going to have another look at parts of the CSA. Some of you will be quite familiar with our Facebook page, and there's lots of videos already talking about the CSA. So my name is Mark Coombe, and I'm a current CSA examiner. I'm a working GP, but I've spent a number of years looking at why candidates pass and why candidates fail. So what we're going to try and do now is distill some of that information to help you if you're sitting your CSA exam shortly. A number of you are already on the 14 Fish, past the CSA and past the AKT package. And I've worked with 14 Fish over the last couple of years to try and distill some of the stuff that you're going to need to get through. And thank you very much for some of the kind comments that you've been giving us. Tonight, as a slight change, I thought what we would do is talk about challenging cases. There's been a lot of questions sent on previous Facebook Lives about cases that you find challenging. And in particular, in candidates that fail, they tend to focus on these challenging cases and take them back to candidates that haven't already sat the CSA. And they find that very worrying, and they assume that the CSA is full of really challenging cases. So what I'm going to do is I'm going to talk very briefly about the CSA and then talk about some challenging cases and how you might approach them. Okay, so what is the CSA? I'm sure all of you are now aware this is a mock surgery in which you're going to be judged on not only your communication but on your clinical skills. And so it's 13 cases and you have 10 minutes for each case. You stay in the same room, so you'll be in the same consulting room, and so 10 minutes consultation, then there's a up to 2-minute break, and then another role player who is simulating a patient will come in with their examiner and you're on to the next case. So the patients are played by highly trained role players, and we've taken loads and loads of feedback on the last few years of the exam. There's no doubt that candidates genuinely feel that the role players feel like real patients. And the patients are accompanied by assessors. All of the clinical notes will be on iPads, and the consultation will start and finish with various buzzers and so on. If you haven't been on the RCGP website, go and have a look on the slide set that shows you what's going to happen in the exam, because it not only shows you, it not only goes through the procedure for the day, but it also gives you an idea what the buzzing noises are like, because they are slightly different. They have to be quite loud because all of the doors of the consulting rooms are soundproof. So when you're thinking about the sort of challenge that you're going to get, all of the cases that have been written for the CSA are very much based on things that you're going to see in day-to-day general practice. We all got together when we first did the exam and sat down and went through the sort of cases that we see every day. And the vast majority of cases are your face-to-face, you with the patient, and just with a simple clinical problem, someone with a headache, someone with depression, someone with tired all the time, someone with low mood, somebody with back pain. But also there's going to be some that are emotionally challenging, or some with an emotional challenge. There's probably only going to be 1 or 2 cases in your palette. So your palette is just the mix, like the recipe for your 13 cases that you're going to get in the exam. And so in that palette, so in your 13 cases, you're going to get 1 or possibly 2 which are going to be challenging. So what I did was with my local registrar group, I got them to sit down for 10 or 15 minutes and write down cases that had challenged them in the last couple of weeks. And so we've formulated a list. And actually, it's a very good representative of what you might get in your live exam. And so you might want to take this list down, but equally you might want to make your own list. But don't forget, if you work in a predominantly elderly population, or if you work in a predominantly young population, the exam is about UK general practice, so you can get quite a diverse spread of what might be there. So don't just think we're going to examine you for what's on your practice. We can examine you for anything that you might face in any practice in UK. But don't forget, Common things are common, and we're not going to examine you on loads of bizarre cases. It is mainly going to be on your standard UK general practice. So if you and your partners in the surgery made a list of the cases that came through during the week, you would cover all of the cases that you're going to see in the CSA, I'm sure. So what sort of challenging cases might you get? Well, you might get a demanding patient. And this could be somebody that comes in who wants something that you don't necessarily think they need. So it might be, you know, a chest x-ray or a referral for something. So you need to think to yourself, how are you going to deal with a demanding patient? You're certainly not going to confront them, and you're certainly not going to become aggressive, but you need to use your structure that we talk about in the Past the CSA package. Use that structure to get plenty of information in the areas, in the domains that you're going to score in, and I'll talk about that in a minute. So demanding patients is the first one. The second one is dealing with some sort of ethical issue, and one of the commonest ethical issues is confidentiality. One of the registrars spoke very nicely about a patient's mother that had come in and specifically wanted information about their daughter because they were worried about them. And that's a fairly sort of classic case that we would check confidentiality with. What about emotionally challenging patients? You know, we are getting more and more, we're under a lot of pressure in general practice, and so we're getting more patients that are demanding or who seem to be angry or upset, patients that want to complain. And so that is going to feature in the exam. And all of the registrars in my group had some sort of challenge. The only reassuring thing is that we've got to give you a standardized challenge in the exam. We've got to make it scoreable. And so people aren't going to burst into tears or storm out. They've got to give you 10 minutes. And in that time, if you act in an empathetic, if you act in a sensible and structured way, they will calm down and you will be able to talk to them. What about drug and alcohol dependency? Alcohol is an important topic. There's been quite a change in the Department of Health guidance in alcohol recently, particularly in the number of units. It's now equal for men and women. And there are a series of acceptable screening processes that we're now expected to do, certainly depending whether you're System 1 or EMIS. You'll start to see things like Audit C and the audit screening tool for alcohol. And so you don't need to do those screening tools in the exam. You don't need to remember great long lists like PHQ-9. But what you do need to do is to have a basic understanding of how you would assess somebody with alcohol or drug dependency. So what other ones are going to come up? Well, unreasonable requests. So what sort of unreasonable requests might you get? You might get somebody wanting a sick note who feels that they deserve it because, you know, they paid their taxes. I think that's a fairly classic thing. Some of the registrars who are working in inner city practice said that they quite often get demands from temporary residents for things like codeine, for things like tramadol, and certainly that would be a reasonable challenge. You know, in a case like that, you've got to take a sensible history. You've got to find out, you know, is this a reasonable request, or are they somebody that the practice might have been notified that they're going from practice to practice asking for drugs, in which case you've still got to score in the domains, and we're going to go into that once again in a minute. There's going to be stuff about safeguarding adults and children. There's going to be stuff about patients with special needs. And you need to work out, you know, part of being a good consultant is working out how you communicate with people with different levels of communication skills. And so if when you get nervous, you default into a lot of medical terminology and a lot of complex language, then you're going to lose some patients. And you're certainly going to lose patients who have a low level of understanding. So think to yourself, I mean, that's why I particularly like patient.co.uk as a source of information, because you need to be able to explain to the patient in words that they understand. So have a think about that. What about clinical areas that you don't see much of in your practice, or clinical areas that you find difficult? I think in medicine we're very, very keen to look at areas that we enjoy and look at areas that we're good at. One of my partners to me today said that they were going on a family planning update, And I sort of said, you know, they're our sort of guru of family planning and general practice. Actually, there's very little that they probably don't know about it. And so, you know, going to another family planning thing may not be helpful, but we do tend to do it. So have a think about the clinical areas that you struggle with. And that may be something like, if you're in a young practice, it may be something like dementia, or it may be something like Parkinson's disease, in which case have a look through our library modules. Think to yourself, which of these cases would I find difficult? Are you comfortable with ECGs and headaches and stuff like that? So if you aren't, make sure that you look at the make sure you look at those library modules and think to yourself, if you're going to be in the CSA, what are the risk factors? What questions do I need to ask in the history? And what is acceptable UK management at this current time? What other things came up in our list? Well, breaking bad news is obviously a big one. It's a great test of communication, and that could be something very, very simple, as in somebody comes in for the result of their you know, fasting glucose or hemoglobin A1C, or a review of their blood tests, and actually they just have, you know, got worse. I mean, it could be breaking bad news with a new diagnosis of something like dementia or cancer or so on. You've got to think to yourself how you're going to do that. And I strongly would suggest that you practice that with your friends in your small groups. When you're making up a group to practice for the CSA, make sure that you have a mix of people, a mix of their backgrounds. We'll tend to stick with the sort of people that we get on with in real life. And so as a result of that, we all tend to therefore show, show consulting skills that we've learned because of the way that we are. And therefore, if you're mixing with people who are like you, then you're not going to learn new things. So I'd encourage you to mix in your groups with lots of different types of people from lots of different types of background, and particularly if you can get people from different cultural backgrounds, then that might give you a broader understanding of different methods of communication and how you might be able to score more in the CSA. So don't forget, even on the challenging cases, all of the cases for the CSA are marked out of 9, and you get 3 points for each domain. And the domains are data gathering, clinical management, and interpersonal skills. So when you're watching your friends consult, when you're practice doing role play, make sure you think, what would they score in data gathering? What would they score in clinical management? And what would they score in interpersonal skills? It might be that we talked about breaking bad news. So let's say, for example, somebody comes in for the result of, you know, their fasting blood sugar or a chest x-ray or something. It may be that you then automatically say, well, actually, your chest x-ray is abnormal, and wait to see how the patient responds. But you've got to, at some point, go back. So you've got to go back and data gather a bit. In the CSA, you're not going to be reviewing patients you've seen before. You're only going to be reviewing patients that may have seen another doctor in the practice you're supposedly working. So you need to go back and say, I haven't met you before. Tell me about your history. If the role player insists they want to get the results straight away, that's absolutely fine. You give them the thing and then say, I'm sorry that we didn't get an opportunity to talk to each other, and so I could find out a bit more about you. So do you mind if we go back? Can you tell me the history? Can you tell me how you originally came to have a chest x-ray or a blood test or whatever it might be? And then find out a bit more about them. You're going through the psychosocial, going through the RICE, excluding serious illness, and then you might examine. Although it has to be said, if you don't need to examine, don't bother. If you wouldn't examine a normal surgery, don't do it. So don't feel that you're role playing a good doctor. You role play the person that you are. So 3 in each domain, maximum of 9 in each case. There's no reason why that you can't score 9 in a case. It's not for perfection that we're giving you 9. It's because you do it in a relatively fluent and sensible way. So the maximum score is 117, and there's certainly a number of candidates who've scored over 110 in the exam. And you probably need to score over 75 or more to be safe. Harder palettes, the overall pass mark is easier, and we know they're harder rather than easier because we've watched the cases over their piloting and over numerous candidate watching. So we've got a very good idea as to whether the palette that you're sitting is a little bit easier or a little bit harder, and you will ultimately be compensated for that. So data gathering, let's just go into it a bit more detail. What does data gathering mean? It's the interview bit of the process. It's the beginning of your open questions to get your history, and then by the end of your first 5 minutes, which is in your first section of the consultation, you should then be focusing on excluding serious illness and so on. So your history should be sufficient to reach a diagnosis and exclude serious illness, and you should do a physical examination if it would be appropriate, but that examination needs to be focused. You also need to look at the records. There's lots of evidence to suggest that if we have a really difficult case or a case that we've struggled with, it tends to make us feel bad. We tend to sort of spend the break between the end of the consultation and the next consultation thinking about what we could have done differently. And the problem with that is that you then don't look at the notes. And so if you're not looking at the notes, you won't be prepared for what's coming in next. And it might be that it's a letter of complaint. It might be that there's a referral letter, or there's something on another page, or there could be some results on another page. So make sure that you've looked at the case. Once you've finished the case, leave it and move on to the next one. In the same way in general practice, if you have a difficult case in general practice, try not to let it bleed into the next consultation to affect you and affect their consultation. It's not really fair. So that's data gathering. Clinical management, you should know all about, is explaining the problem or the diagnosis to the patient in a way that they understand, offering effective and safe treatment, using investigations, prescriptions and referrals appropriately, recognizing urgency. So is this a case that needs to go to hospital now? Is it a case that you can review in 4 weeks? Is it a case that maybe if they get worse over the next couple of days, you want to see them again? And so you need to do that. You need to manage risk and comorbidity. You need to encourage health promotion, but only encourage health promotion if it's required. If somebody comes in and they're incredibly depressed and they're having a horrible time and their marriage is breaking down, and they're miserable, sort of giving them a lecture on smoking is probably not the right time. Okay, it's fair enough. If they've got cardiovascular disease, giving them some smoking cessation advice would be appropriate, but not if they're depressed and you're spending a lot of time looking after their emotional well-being as opposed to health promotion. And at the end of the consultation, you need to appropriately follow them up. What are interpersonal skills? You all know about these. Well, it's all about rapport, showing sensitivity and empathy, exploring the patient's ideas, concerns and expectations, listening and understanding, using appropriate language. I told you about the learning. If you're dealing with someone with learning disabilities, then you need to explain it clearly. You need to explain it so that they understand it. You know, what words do you use? You know, when you go to the toilet, what is it? You know, rather than talking about feces or whatever that might be. You know, you've got to use terminology that people understand. You need to talk about what choices there are. And, you know, once you've found out from the beginning of the consultation what choices they think they would like, then you can obviously add that into your explanations. And you need to respect autonomy. You know, sensible people with competence are allowed to make irrational decisions. And so they're not necessarily going to make decisions that you think are the right ones. So you've got to talk to people and give them an understanding such that with the beginning of the consultation, so you and the patient are there and you're talking together, and all the way through the consultation, then you follow together and you're continually checking to make sure that you're understanding, such that at the end you finish talking the same language and so on. So everything that you need to know on how to pass both the AKT, but in particular in this case the CSA, is on our Pass the CSA package. There's some excellent examples of some of the challenging cases that I've talked about tonight. You really do need to work in your small groups. Work together to make sure you cover as much, get as much experience of consulting as you possibly can. Use your TPDs in your trainers. I've spent quite a lot of time over the last year with 14 Fish going around the country looking at training programs and helping trainers in their TPDs. And there's some excellent training programs out there. And if you ask for their guidance, they really will support you. So it doesn't matter who you are. With focused learning, you certainly can pass the CSA and you can consult well. And the CSA isn't just about an exam. It's there to help you consult for the rest of your career as a GP. And certainly on a regular basis, the stuff that I teach on the CSA package, I use myself to help myself negotiate through the consultation. So good luck. I was at the CSA exam last week, and there were some brilliant candidates there. So good luck to anyone who's sitting between now and the end of the exams. We'll do another Facebook Live if people want it, either on the AKT or the CSA, and we'll put that date out fairly soon. If you've wondered, if you hadn't seen a Facebook Live before and you've wondered who's sitting on the couch for me this evening, it's one of the fantastic administrators from 14 Fish, who does an awful lot with the AKT and CSA, and she's really here to monitor the questions they come in and ask them at the end. Well, I think I've been yakking on for more than long enough, and so if there are any questions, please send them in. If you've got them afterwards, we'll cover them in the next day or so. But Liz, have we got anything that anybody wants to ask?
We've just got a question here. So how many challenging cases can I expect to see in my exam? Okay,
so that's really good. You'll, particularly if you haven't sat the CSA before, rumour control will tell you that it's going to be your worst nightmare of 13 really, really challenging cases. That isn't the case. The easiest cases for us to mark are very straightforward ones. So people with an upper respiratory tract infection, people with ear pain, headache, chest pain. But you're probably going to get one or maximum of two challenging cases of the sort of the sort of challenge that my local registrar group have come up. I think they've come up with a brilliant list. So one or two.
We've just got a question here from Matthew. He says, with regards to examinations, are we expected to check the BP or listen to heart sounds with the patient?
Okay. You don't have a SFIG to take into the exam. It's not part of the list at the moment. But if you would do a blood pressure, I would definitely say that I would like to do a blood pressure, because, you know, if you were going to do a cardiovascular exam, you would expect to do their pulse, do their blood pressure, and then listen to their chest. We as you know, Matthew, then there are no abnormal clinical findings in the exam. So all of the patients we've examined that morning to check they don't have findings. But if the case has abnormal findings and you examine properly, you will then be handed those findings on a card. If your examination, and last week I saw a couple of candidates examining patients through the shirt, or doing doing an abdominal examination without lifting a shirt up or whatever, you won't get the clinical findings. So you must examine properly. And you know, if there's something you would do normally, but you don't have the equipment, just vocalize it. And the examiner will let you know if it's normal or abnormal.
I've just got a question here from Kazan. He's asking if you can use the BNF during the exam.
Yeah, absolutely. You are allowed to take in both adult BNF and the children's BNF. And a vast majority of people put coloured tabs on the side so that they can go through. The BNF has got paper like toilet paper, hasn't it? And when you're a bit nervous, it's really difficult to sort of get through to the right page. So if you want to put the tabs on, that's absolutely fine. But whatever you do, don't have notes and don't write on the pages, because it looks to us as if you've taken in additional information, which would be considered as cheating. But definitely you're allowed to take both in. Have a look on the RCGP website on the equipment list that you're allowed to take in, and make sure that you've got it set aside. So put it in a bag, get your partner or your friend or somebody at the surgery just to check you've got everything that's on the list.
Sorry, just got a question here from Matthew again. He's just asking, it's just this question here. So you met with the heart sounds, listening to them on the couch, or is it okay with them standing, sitting without a shirt? Okay,
yeah, no, that's a really good question. Do you have to examine people on the couch? Well, I think it's fair to say that I've done 2 surgeries today, and I've seen, I don't know, 30 or 40 people. I probably put 3 or 4 on the couch. So if you need to put them on the couch, so for an abdominal examination, yes, put them on the couch. But no, I think it's perfectly reasonable to listen to a chest with them standing up, or listen to heart sounds with them sat in the chair. If that's how you do it, and you look comfortable and you look competent and you look as if you know what you're doing, great. I certainly would do that. I certainly would do that in my surgery, and I'd do that in the exam. That's a good question.
Thanks for your questions, guys. We've just got another one here. So my friend had a 14th case. Will we all be getting 14th cases?
Okay. So the 14th case was piloted last year. The reason the exam is always, and the examiners are always looking at ways to improve the reliability of the exam, to make the challenge a more valid representation of UK general practice. So there will be things that will be piloted over the next couple of years, 2018, 2019. So last year we did pilot, so that means it doesn't count, and you were asked if you wanted to volunteer to do it. We did do a 14th case, which was a written case, and it was very much based on the complexity of prescribing. So you're asked to a nursing home, and they want you to help them with a new resident that's got lots on their prescribing list. We looked at the piloted case. It didn't particularly add anything. So in 2018, the 14th case, if you get asked to do one, you're perfectly allowed to say yes or no, but it wouldn't count towards your exam. So yes, some of you may get a 14 case. Yes, in 2019 it may be based on a different structure, but please don't worry about piloted cases. You will be warned about it. The other thing to remember is, don't forget that a few of you will get a home visit case and a few of you will get a telephone case, and certainly don't worry about those. Have a think about the sort of things that you get on a telephone case in your surgery, about children on the phone. The average consultation time in UK on telephone consultation is about 5 minutes, and so actually a telephone consultation in the exam it should be relatively straightforward. But use your structure, ask the questions, make sure you exclude serious illness as you would do on the telephone in the surgery. Home visit cases, you'll be taken from your designated consulting room for the day, and you'll be taken to a home visit room where you may well find the role player is in a mocked up room, so they'll be in their bed or whatever. And once again, the sort of classic things that you're going to get, that you get in the surgery, terminal care, particularly palliative care, an elderly patient that's off their legs, somebody in a nursing home, that sort of thing is going to come up. And so make sure you're comfortable with the sort of structure that you're going to use, and in particular, things like pain relief, analgesia. And in those particular cases, particularly when you're on a home visit, because you won't have the computer to hand, you may well be asked to write a prescription. And I think it's perfectly reasonable for the exam to expect you to write a valid controlled drug prescription, for example. So have a look in the BNF, look at the rules, and make sure that you can do it. I know that we all get a bit rusty because we tend to use the computers in the surgery, don't we? So make sure that you know how to write a prescription, particularly for that event.
Cool. I think that's it for the questions this evening. Thank you everyone who asked.
Yeah, thanks ever so much for that. And thanks for all of those people who signed up and showed interest. I hope things are going okay for you at the moment, and I hope your preparation is going well. And really good luck in your exam, whether you're doing it now or in the next sort of diet after the summer.
Thanks, guys.
Bye.